invite you to ask questions throughout the course of this time, and really hope that you'll share what you learned here today with members of your family and your colleagues. Thank you so much. Next.
Thank you, Sherry. Thank you, Sherry. Can everybody hear me okay? Great. Well, as Sherry indicated, we're very excited to be here, and we have a great panel. And actually, when Sherry asked me if I would be willing to moderate this, I said, when I heard who the panel was, I said, I think even I can't screw this up. So, again, we're here to talk about a very important topic. And first of all, I'd like to really thank the co-sponsors of this event, which is Greater Fort Wayne, Inc. and Parkview Health. This topic, I'm sure you hear about and read about it in the media a lot. And really our focus today is really going to be, how from a business community, kind of what's the impact. We're really going to cover several areas. One is really kind of what's the magnitude of the problem here to really kind of understand that. In addition to the magnitude, we want to understand who are these people. I think there is a lot of confusion about who are these people out there using opioids. Another thing that we'd like to talk about today is really, so you as a business or as a parent, as a community member, why should you care? Why is this important for you to pay attention to? And then lastly, is really talk about what are some solutions around this? What are kind of some next steps? What can we do? So again, the intent today is to be very conversational. Technically, we have clear up till 1:30. We'll kind of keep this going as long up until that time or end earlier if the conversation kind of ends. Informal that we're going to take questions throughout this panel. So if you have a question, just raise your hand, and I think Sherry will have somebody go around with a mic to get that. So I'd like to introduce our panel, and they've asked that I not read all the things that are in front of you. So I'll kind of hit some highlights. It's my pleasure at the end of the table to introduce Dr. Deborah McMahon. Dr. McMahon has been the Health Commissioner of Allen County since May of 2000. I think those of you who know Dr. McMahon, you're really talking to somebody who's an activist improving the health of this area. I have had the fortune to work with Dr. McMahon since 2008 on different topics, and she's just somebody who brings the attention. We would not have a needle exchange here in this community without her leadership, and there are many other things that Dr. McMahon has done to really help make a difference, and she does that as really with a team of people and very participatory in how things are done. And I know at some point she's going to talk a little bit about the opioid task force. In addition to that, sitting to my left is Captain Kevin Hunter over Vice and Narcotics Division here in Fort Wayne Police Department. He's been with the Fort Wayne PD since 1989. And if you want to know what's happening in Fort Wayne around substances, illegal substances, Kevin is the person, and he's done a great job in this role of advocating how to improve our community and reduce the drug usage. And then last but not least is Marcia Hoff, who is the CEO of the Lutheran Foundation since 1995. She's been the CEO there. Really, I can't say enough about what Lutheran Foundation has done, especially regarding mental health. Several years ago, the Lutheran Foundation decided to focus in on mental health and substance use disorders. They did a baseline study where they interviewed a lot of people throughout Northeast Indiana. I have to say, when I participated in the study, and when I shared the findings, when the findings were shared, I'm thinking, oh, well, I think I knew all of those things. And I did realize what really was happening is they were reinforcing what needed to be done. And Marcia and the Lutheran Foundation have used that basically survey, that data, to really put an action plan into place, and they're making a huge impact in our community around mental health and substance use disorders. So I really appreciate the leadership. So I think just to start out, if you could give a round of applause to the great panel we have. So to get started, Deb, do you want to go ahead and talk about a little bit about what's in front of folks and the opiate task force?
Well, sure, thanks. And thanks for having us here. We really appreciate the opportunity to talk to folks who may not be as aware of this public health crisis. As you've probably heard me say many times, the largest public health crisis I've seen in 17 years. And as Captain Hunter, or as we call him, Captain Sunshine, will tell you, we're probably just at the beginning of it. So we realized in 2010 that this was really becoming a problem when we had more deaths from accidental overdoses nationally than from motor vehicle accidents. And that's when the CDC began to really look at this and begin to understand that these drugs that had been prescribed for legitimate pain reasons for many years were probably not as safe or as effective and were even more addictive than they had previously thought. It was around that time that we initially started our opiate task force, which is a multidisciplinary group of folks, and we're always willing to have more folks be a part of this. It's health, mental health, law enforcement, the judiciary, folks that are involved in addiction themselves. It's a public-private partnership that really, I think, has really began to try to develop an infrastructure, began to deal with the problem of this magnitude, because right now, everybody was trying to do their own thing. And the problem is, with this complex of a social and systematic problem, you really do need to have a coordinated response, and that's what this task force has really been trying to do. I'd like to acknowledge some of the members. Judge Wendy Davis, she was also on the Governor's Commission and Task Force for Drug Abuse, runs a very great court program that really tries to get a lot of these folks into treatment. It's just incarcerating them, and has really worked with Marcia and Paul Wilson and other folks to really try and expand our capacity to handle that situation here, and maybe get a little more from her later. Mickey Ashpole, who's been a dynamo, really trying to bring awareness to this issue and try and really light a fire from the grassroots perspective. And then Stephanie Crandall from the mayor's office, I think I saw her here, has really been helping us look at some of the logistics legally involved in some of the things that we can do here as well. So really, is there anybody else from the task force that I missed? We've really been very fortunate to have this group of people working, but I'll turn it over to Marcia, but this is really the biggest public health crisis I've seen. One more thing I do want to say in case I don't get a chance later. I think a lot of people, actually 1 in 4 in this room, probably either know somebody or struggling with addiction itself. That's what our national surveys tell us. So there's probably at least 10, 12, 14 people in this room that are struggling, and maybe silently. But what I want most people to understand who don't interact with this either professionally or personally is that most of these people, and we estimate here in Allen County of 370,000 people, there's probably 40,000 people misusing opioids. Now, they're not all addicted, they're not all shooting heroin, but they're on that pathway. 40,000 people. Many of them are probably working for you. But what I want people to understand is most of those people started on these medicines for legitimate pain reasons. They did not start on this because they were looking for a thrill or euphoria, or they wanted to get high. They started on them because they had chronic pain. 100 million people have chronic pain in America. That's a third of our population. We do 1 million spinal procedures a year. We do more than that. We do probably 5 million orthopedic procedures a year. And that's not including all the trauma, all of the other problems, the diabetic neuropathies. There's a lot of pain, and people became addicted to these medications accidentally. So we need to keep that in mind. And most of the people of that 40,000 who are misusing opiates would deny that sincerely, that that's even a problem. So keep that in mind when you're hearing about this crisis. hearing about the overdose, we're hearing about the people that are affected. These aren't those people, these are us. These are people who had legitimate reasons for trying medications, taking medications. And sadly, the medical and the public health community found out too late. They're neither as safe as we thought they were, they're much more addictive than we thought they were. So just keep that in mind when you hear future stories from today and future stories.
So I just want to share some stats with you. 90% of all adults with substance use disorders started using under the age of 18, half under the age of 15. 60 to 80% of adolescents with substance use disorders have co-occurring mental illnesses. And about 40% of those with substance use disorders have identified with mental health issues. 3 in 10 teens believe that prescription pain relievers are not addictive. And 50% of teens believe that prescription drugs are much safer than illegal street drugs. Americans make up less than 5% of the world's population, but use 75% of the global supply of opioids. And something else that I want you to know as a business person, a business owner, the Fairbanks Foundation with the IU School of Policy and Public Health did a survey. They found out that 80% of Indiana employers have observed prescription drug misuse by their employees, 80%. I want to add to Deb what she said about those people. I don't care who you are. I don't care where you live. I don't care what color your skin is. I don't care how young, how old. This impacts everybody. And so as we started, we've done a lot of public speaking, but every time that I go talk to a group like this, somebody comes up to me afterwards and says, oh, you know, I had a family member, or I knew someone. So what we all need to do as a community is embrace this issue, because it's impacting every area of our lives.
Thank you. I'm going to reiterate what Dr. McMahon and Marcia had said as well. There's been a lot of good work that we've done so far on the opiate task force. We've got a lot of work ahead of us. But as Dr. McMahon has said, this is going to get worse before it gets better. And she's calling me Captain Sunshine, which I understand why. But when the numbers come out, it's very disheartening to see such large overdose numbers in this community. And it's not just this community, it's nationwide as well. I just got the July numbers for this year, and we're at 153 overdoses in July compared to 41 the year before. So that is a significant increase. And the most recent overdose death numbers that we have, we're at 55 overdose deaths for the year so far, confirmed drug overdose deaths, and then there are 30 outstanding cases that are pending toxicology results. So if all those 30 come back as being drug overdoses, we're on pace to set a record, unfortunately, for drug overdose deaths. We are doing everything we can to address this issue. We have done so many public speaking engagements and just trying to educate as many people as we can on the seriousness of this issue. And Marcia's right. Almost every time we go and do one of these events, somebody comes up and says, I have a neighbor, I have a cousin, I have some family member that has an issue with opiate addiction. It is everywhere, unfortunately. We're seeing it and doing everything we can.
Thank you. Thank you, everybody, for that. I guess, one of the questions I would have is that, what do these people look like? These people with opioid problems that are abusing opioids. Are they, I remember growing up and in high school seeing films about these heroin users in the inner city, and just seemed like a really dirty drug that, they're in some dirty room sitting around and using dirty needles, and I'm thinking, that's nothing that I would ever get into, and none of my friends would get into it. But now I'm hearing, talking with Captain Hunter earlier, we're talking about high schoolers, and actually I was at a meeting last week where the mayor of Wabash shared that he has 2 addicted daughters, one addicted to methamphetamines and the other to heroin, and they became addicted in high school. And now he's raising their children, an 18-month-old, I think like a 3-year-old, and like a 4-year-old. So the panel, if you could just talk a little bit about who are these people?
I could start by, we did, and every year we do an overdose study, but we looked at all the accidental overdose deaths that occurred from 2008 to 2015 in Allen County. And it was a collaborative process with Fort Wayne Med Ed and the coroner's office and our department. And what we essentially found was that these people are you and me. Most of these people did not intend to die. It was an accidental overdose. Most of them were taking prescription medications, but they were taking a lot of different medications, some that they might not have known were interacting with each other. Most of these people were working. Most of these people had education. Most of these people look like you and me. They're not as described earlier as these. Yes, there are certain people who are based on a lot of issues that probably occurred in their childhood that we'd be happy to talk about, are becoming addicted early in life, and maybe they're following the pathway that Chuck described. But a lot of these people are people who started taking, again, medicines for legitimate pain reasons. As we became aware they were unsafe, the legislation moved in, and now there are new prescribing guidelines for physicians, so we have to follow rules to be able to prescribe them. So the legitimate supply is shrinking, but you still have people that are addicted. And so they're turning over, they're becoming that new person that Chuck was describing earlier. The other thing I just want to say too, that the thing that concerns me, and I'm sure Captain and Hunter and Marcia too, is that in the day, drugs were fairly benign. Back in the day, pot was like 5% THC. Back in the day, heroin was pure opioid, didn't have fentanyl and carfentanil and those kinds of things. So if you as a 15-year-old person with an undeveloped brain, prefrontal cortex, didn't have the smarts to think, geez, I shouldn't take these drugs, you could maybe experiment at a party or have somebody push them on you at a party, and you did it once or twice and thought, God, I'm never doing that again, and never did it. That may not be an option for the kids today. They may be in the same situation you and I were in. They may be at a party and feel some peer pressure to do these, but these are not the drugs of the day. These drugs are so potent. We have had many people tell us, and Captain Hunter can affirm this, that with one dose, they're hooked. One dose of spice, and you can be psychotic for the rest of your life. So they're not, it's the same games that we played when we were adolescents, and again, you got all the peer pressure, all the hormones, and none of the prefrontal cortex judgment, and so you're doing a lot of silly things, but the rules have changed. The game has changed. And so we have to look that this is going to be an evolving crisis, and the people are going to look different than back in the day.
So we've got, it seems like the Blue Million task force working on all kinds of stuff, but on one in particular, there is a community advocate, and her name is Andrea. And she's a community advocate because her daughter, who she would have never, ever, ever thought would get into drugs, with her boyfriend, I think, last May, end of May, used heroin, and by September, October, she said, Mom, I don't think I can beat this. I've tried, I don't know what to do. So Andrea said, let's find some treatment. It would have taken 4 to 6 weeks to get into a residential treatment center. And Andrea said, we don't have 4 to 6 hours. So similar situation, her daughter overdosed. And it's coming up to a year this fall. October? October. So, yes, she died, overdosed and died. And so I say that because Andrea is one of those that's raising 3 daughters that don't have a mom because of drugs. Somebody she would have never, never, never suspected. So one more story. So I was in Adams County last week, and they had their first ever opioid symposium. And there's a panel of people. One is a guy who was incarcerated and received Vivitrol in jail, and he is clean a year. And I went up and I said, congratulations. And I said, tell me your story, and he told me a little bit about it. But the saddest part, I think, of that whole panel was grandparents. they had a grandson, who had been living with his mother. He's 27, and they knew that he was using heroin, so they wanted him to come and live with them, and he did. And this grandfather wasn't the blood grandfather, but he said, I loved him like he was my own grandson. I taught him how to hunt, we did all kinds of things together. So they're 4 months into this, and the grandson says, I'm gonna go back and see mom for the weekend. They're like, well, okay, but text us, call us, do all that. So they got a text because he liked to scratch off lottery tickets, and he won $100 in a scratch off. He's all excited, wow, I got $100, and they're like, great. But they got a text at midnight saying it was okay. They got a text and a phone call the next morning that he died. So he shot up what he thought was heroin. It was pure fentanyl. And so they're like, all this guilt. They're like, oh my gosh, what should have we done? What could have we done? And I guess I want to just jump on Dr. McMahon's comment, because these drugs are so addictive that they would risk getting a drug that they don't know what it has in it, and they die instantly.
Well, I'll go along with that line of discussion. We really started noticing a huge problem with fentanyl in July of 2015. I got a call, it was over the weekend. There were 3 drug overdose deaths in a 24-hour period, and at that point, that was a rarity. We started looking into it. I called my team in on a Saturday. We started investigating. Come to find out, 3 people went to one dealer, all bought what they thought was heroin. They left. The first person used what they thought was heroin, died instantly. The other 2 people saw this person use that substance and die, and left and went their separate ways. Those 2 people also used the same substance and died as well. So it goes to show you how strong this addiction is. If you see your friend die from using a substance, yet you decide you have to use it anyway, it's mind-boggling. So fentanyl, to give you an example, is a synthetic opiate, and it's 100 times more powerful than morphine. So there's something that's new on the market right now, or a drug market, called carfentanil. How many of you have heard of carfentanil? Okay, so carfentanil is 100 times more powerful than fentanyl. So just looking at it, you can probably overdose. It's that strong of a substance. We have seen our first carfentanil overdose death in Allen County, and that's a scary thing because I don't want to start seeing that on a regular basis like we saw fentanyl in our community after those overdose deaths. It's very scary, and that's the issue. People buying drugs on the street, they have no idea what they're getting. It could be heroin, it could be heroin and fentanyl, it could be carfentanil, it could be another form of fentanyl, or it could be something completely different. And people are dying as a result.
So it's obvious this is really bad stuff, and we're hearing this is impacting people from all walks of life. It's tearing apart families, a lot of grandparents raising their grandchildren. When we look at who's doing it, there are many people who are abusing opioids that are working every day. And you as employers have them in your workforce. So is the way we get out of this situation is just enforcing the law even stronger and reducing access? Kevin, I guess I would start with you. Could you talk about that?
Well, I've heard this said by others, and I've said it myself. There's no way we can arrest our way out of this issue. It's too big of an issue. Too many people are affected, and the criminal justice system is not set up to deal with the magnitude of this issue. I think Judge Davis would agree with me on that. Yes, we still have to hold people accountable for doing things that they shouldn't be doing, but the person who is addicted, that's all they're doing is feeding that addiction and not going out and committing crimes. That's certainly a problem. Now, the dealers that are spreading this poison into our community, it's my opinion that they should get very severe penalties and be held accountable for what they're doing to our community. I think that answered your question.
Thank you. Thank you, Captain Hunter. Other panelists, would you like to respond to that?
Well, I think we can't just arrest our way out. I totally agree with Captain Hunter, but I'm totally for really punishing people who are selling these drugs to folks. But I think part of the problem is we're not doing a very good job at recognizing and addressing and destigmatizing garden variety mental illness. Just garden variety depression and anxiety in young people. I mean, the average age of development of mental illness is 14, and it takes that average child about 8 to 10 years to get any treatment. And I don't know if you remember your childhood, but I just remember the teenage years as being very traumatic. And so I can't imagine going through there with a significant anxiety issue or a depression issue without self-medicating in some way. So by family members, by community members, by teachers and doctors not recognizing that and getting kids the effective tools that they need to be able to deal with this, we're just setting them up to be a victim of somebody coming along and selling them something that's going to make them feel good. And that may be drugs, it may be more shoes than they need, it may be donuts, I don't know what it is. Maybe some boy telling them they're pretty. But we're setting them up to be victims of somebody taking advantage of the fact that they know they aren't feeling right. Something's not right. So we need to, first of all, mental illness is just a medical problem that happens above the neck. There's nothing moral about it. It's like addiction. There's nothing moral about it. They're just medical problems, and they have medical solutions and medical treatments. We just need to be very real about that. And when people are struggling, whether it be our children, whether it be our parents who are elderly, whether it be, I mean, diabetics have a 50% more higher rate of depression than the average person. If you don't recognize these things, you make them vulnerable to becoming addicted to medications that, once again, are prescribed for very legitimate reasons. So first of all, destigmatizing, recognizing, and addressing mental illness is, I think, one of the first things we need to do. The other thing we need to do is create, and that's something that's been very, very challenging, very, very difficult, is to increase the capacity for people to get care. We do have treatments for addiction right now, whether it be alcohol or drugs, we do have treatment. The one thing that I am concerned about is spice. I'm not sure if we know how to really treat that, to be honest. But for opiate addiction, for alcohol addiction, we do have treatments for that. But getting physicians to, again, be willing to take on patients who they are going to perceive are going to be a time sink, or going to be a problem, or going to be difficult. We got to get them to get over their bias. We got to get pharmacists over their bias. We've got to get people connected so that we have better communication between mental health, law enforcement, and medicine to be able to actually provide an integrated treatment plan for these folks. There is hope, but there's not hope if we don't develop the infrastructure to increase our capacity to solve this problem.
I think the other thing that I would add is if you're a parent or a grandparent, we need to talk to our kids. And we need to be really open and honest about this. It's something we shouldn't be afraid to talk about. And if we don't, we may be sorry that we don't talk about it. And then I also want to tap into what Dr. McMahon said. We all do a lot of public speaking, and so we talk about if we had coronary disease, you wouldn't tell me to stop taking my medicine. You wouldn't make fun of me, you wouldn't treat me differently. But if I were in bed, because I was so depressed I couldn't get out of bed, that's a no casserole disease, right? In your church, you make casseroles for everything else. You make a casserole for a baby, you make a casserole for an operation, but you don't make a casserole for depression or anxiety. And those are the two most common things. If we can address those issues early on, it would solve so many other problems. I did a really stupid thing about a year ago, fell down, broke my hand, broke these 3 fingers, got casted. The guy said, "What color do you want?" And I said, "Purple, it's my favorite color." He said, "How about sparkles?" I said, "Sure." So I'm out talking and I said, I can't tell you how many people stopped and asked me what happened to my hand, but nobody would have asked me sincerely, "Marcia, how you doing today? Got any anxiety going on?" I might. But so we have to be able to talk about a broken hand and a brain disease in the exact same way. And some of these people that have substance use disorders may have to be on medication for a very long time. So we can't say to people, suck it up, get over it, and move on, because that may not ever be the case.
Can I
to kind of tie this back to you, I think one of the things that is going to be imperative if we're going to actually have any potential to really resolve this problem is that you as employers get involved. And again, looks different because what I'm asking you to do is collaborate in a very functional way, not just a hi, how are you, but a functional way with medicine and mental health. Because people are struggling in your workplace. And we need to develop employee assistance programs or other types of programs that actually not only educate people about this issue, so perhaps they could self-identify as somebody that's struggling with depression or anxiety or substance use disorder, but then be able to get them in a non-stigmatizing way into treatment. Without your partnership, because that's where people who are employed, that's where they're at the workplace. And so we need to have 21st century medicine needs to look very different. And I'm very grateful for our colleagues at Parkview and other places that really recognize that. 21st century medicine is not going to happen exclusively in the exam room. It's going to happen in the workplace. It's going to happen in other places as well. It may happen in the church. It may happen in wherever people are. That's where healthcare needs to be to address some of these really important issues. And it's not just medicine. It's mental health. We need to be in the jails. We need to be in the courts. We need to be everywhere because that's where the people are. So the medicine, people can't come to us. We need to be going where the people are. But unless you make a receptive infrastructure that allows us to come in and partner with you to provide those services to your folks, it's not going to happen.
I'd like to add something to what Dr. McMahon and Marcia said. Talking with your children is a huge thing. And today's marijuana is not the marijuana of the past. There's a really good video that was produced by the FBI and DEA called Chasing the Dragon. If you haven't seen this video yet, I would highly recommend that you take a look at it. It's on YouTube. You can watch it for free. And it's about 40 minutes long, and they talk with different subjects that eventually got addicted to heroin. And almost every one of those people in that movie talk about how marijuana started it for them. Marijuana opened the door for them to try other drugs. And I think having those discussions is very, very important because we don't want our kids ending up on this stuff. And just by trying marijuana, that could lead to that. Now, again, not everybody that smokes marijuana is going to end up using heroin, but I wouldn't want to take the risk. A recent trend, we've talked about spice. Spice is not an opiate. Spice is a synthetic cannabinoid. The issue with spice is it's nothing like marijuana. We've seen a recent spike in overdoses with spice, and some of the information that we've received recently is that spice is being laced with fentanyl. We're still looking into that. We've not confirmed any cases, but nothing would surprise me at this point because that would be even more addictive than what spice is. Because if you add that opiate component, it would get people hooked very quickly. Indiana has been for a few years now the #1 state for pharmacy robberies, and again tied back to the opiate epidemic. The last, I think, 3 years running now. Now, fortunately, Allen County, we've not had too many pharmacy robberies, and the majority of those are in Marion County, where their problem is even bigger than ours. So it is a problem, and we're still working on it.
Thank you. As you can see, we've got probably one of the most knowledgeable panels around on this subject, and with Captain Hunter's experience of seeing it day in and day out of what's happening around here. So I think we'll pause and start taking some audience questions. And before we do that, one of the things I want to say is that I heard Senator Jim Merritt, who has really introduced a lot of legislation around opioids and dealing with this problem, and actually talks about killing heroin in 5 years. I heard him last week talk, and this kind of goes back to stigma and really the importance in talking and starting this conversation, talking with your loved ones, talking with your friends about this topic, talking in the workplace about this topic, because as he said, you know, this opioid problem is not a character flaw. These people who are using opioids. It is an illness, and I think, as Marcia mentioned with the cast, when she's walking around and people asking her, we really need to look at this differently and really need to be starting that conversation. So do we have, before we go any further, do we have any questions in the audience?
I'm just curious about the source of the drug. I'm curious about the source of the drugs. You talk about fentanyl being so powerful and being mixed in and making it pretty deadly. I understand that it starts with prescriptions for real reasons, but where are the dealers getting the fentanyl, and why is it so prevalent? You know, I mean, I'm thinking of, you know, how do you stop it at the source?
Well, we know from information from the DEA that fentanyl and heroin is coming in from several different sources. China is one source and Mexico is another. The theory is when many states in the United States legalized marijuana, that cut dramatically into the Mexican drug cartel's profits, and they had to make up that profit margin. So instead of growing marijuana, they started growing poppies. And then also along with that, they either shipped fentanyl in from China into Mexico and then got in through the southern border, or they made clandestine labs in Mexico to make the fentanyl and ship it to the United States.
Sherry, we have another question right over here.
She asked my question already.
Oh, okay.
I'll just ask this question then. Aj Patel went to Senator Donnelly's office, and the senator supported the 21st Century Cures legislation, which provides, I think, about $10.9 million initially to Indiana. What is Fort Wayne and Allen County doing with respect to that, in terms of trying to tap into some of those funds?
Perfect segue, thank you. So Senator Merritt authored, 20-some bills that included opioid somehow, something. So he approached a group of us, Judge Wendy Davis, because he served on the governor's task force, or the Attorney General's task force last year. And Kevin Hunter worked with me, and Tom Allman, Park Center, and we went and defended Senate Bill 510. Senate Bill 510 is to bring sober living facilities for those that are in the court system. So right now, our jail is at capacity, and so if Judge Wendy Davis has people in her courtroom that she could send someplace for treatment, right now there are not enough places for those treatments. So we were approved for $1.5 million. We have to match that locally, $1.5 million. And we are developing a sober living facility with what I'm going to call 24, what you think of as intensive inpatient beds, and then 60 sober living beds. Now, can I say what you said yesterday, Judge?
Sure.
Okay.
I don't know what I said yesterday.
No, this is so. We met with DMHA yesterday because the whole confusing part about the CURES money, I'll say two things about it, and then I'll get back to the judge's comments. But so Ohio, which they have a big problem, but they got nearly $30 million. So Indiana gets 10.9. We say why? We don't collect enough good data. So we can't tell our story to get more funds. So we got to do better at that. And then, so Judge Wendy Davis says yesterday when we're meeting with DMHA, in her court, she had 5 people that she could send someplace. And luckily, Park Center opened a unit Tuesday, August 1st. And they're going to have 15 beds, I think, until we can get this facility up and running. And so the people will be transported from the jail straight to the facility, and then they'll have all the care that they need there to help them be successful in becoming sober. And it's all through the auspices of the court. It's driven by the court. Now, I'll say that we also, so we're going to need to raise money, guys. local money for that, to get that match, because if we don't, we won't get it. The second thing that I want to say is that if you're not in the court system, there aren't enough sober living beds either. And so we have got to work on that problem as well. And the Lutheran Foundation is starting to work on that in a small way, but we have got to have more sober living facilities for men and for women. So Paul, I don't think he would mind if I said this, Paul Wilson. So we have a site identified, and he was meeting with some of the neighbors around that area to make sure that they weren't, upset, that kind of thing. And he had a number of people come up to him afterwards that said, where can my child go if they're not in the court system? I need a place where I can send my child that's addicted. He had several of those comments. So while the court system is very important and we need to get people out of our jail and into treatment, we need to work on sober living for everybody like you and me.
Thank you, Marcia. Other questions out there?
Chuck, I wonder if Judge Davis would want to talk about the impact of this crisis on her courts, I don't know, as part of the task force.
That'd be great. Judge Davis?
I think these guys are tired of me talking about it, but really and truly, I know Dr. McMahon, everybody sitting up here sat in my courtroom before.
Visitors.
As visitors, yes. As visitors. So every Monday morning, I can have up to, I take the bench at 8:30. Just so everybody knows, I only do felonies. If you're in possession of heroin, that is a felony. So I know Captain Hunter's Vice and Narcotics, they are arresting people so much that we are overloaded in the criminal justice system. But let me just give you an example of this Monday. Today's Wednesday. I took the bench on Monday morning, and I had about 32 cases, almost all opiate addicted. So in the criminal justice system, evidence-based practices tell us that we bifurcate out the drug cases versus the violent offenders. So I have all my drug cases just in one morning, 30 plus. That's where she got the 5 that I mentioned the other day, because I had one guy that went to Trine on a scholarship for lacrosse. He got really badly hurt in a game, got prescribed opiates after orthopedic surgery. He's now been on the street for 3 years shooting heroin. I looked at this kid and I thought, I've got a college student and a senior in high school. I thought this could have been my kid, because my kids are athletes. I had a mom tell me that if heroin was in the middle of the street or her child was in the middle of the street, she would go after the heroin. That's another really big issue we have. One of the individuals I had to get out of the jail is 8 months pregnant, who has been shooting heroin since she told me, since she's been 14. And so these are the individuals that on one given morning, we are problem solving what to do with them. Sheriff of Allen County and the police force, everybody is in agreement that they cannot be incarcerated. However, the reason why I got so involved with the Senate Bill 510 is because they are committing crimes. And so y'all didn't elect me to necessarily be a social worker every day on the bench. So, which is what sometimes on Monday mornings I feel like, which is okay because that's where we are at in our country. But we've got to get them out of the jail. We've got to get them court ordered into treatment. Most of them, I run another program. It's a probationary program. Right now, I just checked the statistics. I have over 280 individuals in this release program to probation. But the probation office is taxed. Our community corrections is taxed. I had lunch with the sheriff. I told these guys yesterday, he's saying, how can I help you get these people out of my jail before I get sued again? So it is really, really a huge problem. When we looked at the jail, probably over 50% is due to drugs. So if you think through that, right, so I think we can all agree jail and prison are for those that are molesting our kids, that are shooting people, all these violent crimes. That's why we have bars, right? That's what we as judges, criminal court judges say, that those people hurting my community have got to get, that's why we have this. The problem is our incarceration rate for these heroin addicts are off the roof. However, when I have a heroin addict, like I did Monday morning, tell me she's been sticking a needle in her arm every day for 7 years, I can't look at her and go, okay, well, I'm going to release you from jail today. Please don't do that anymore. It just doesn't work that way. So we are diligently working that we can court order those individuals. And the funny thing about the 5 people that I talked about from Monday morning, Park Center's facility wasn't even open yet Monday morning. It didn't open till, was it today, August 1st? So Monday was the 31st. I court ordered already 5 into this facility, and I had more, but I'm going to tell you, my friend Judge Gall, who runs our drug court program, we fight over those beds. So I had Hope probation in the morning, and she had drug court in the afternoon. So we made a deal that I wouldn't fill up all the beds before she could have a drug court that afternoon. So anyway, it is a problem. I don't know if that answers your question. In the court system, we are just absolutely overloaded. But I think that the judiciary, the Indiana State Judiciary, is really pushing in the direction of problem-solving courts, which is a really good thing. We have a vet court, we have a reentry court, we have a restoration court. Really here in Allen County, we are very sophisticated in our court system, but we are still to capacity plus some. So I guess that gives you a little flavor.
Thank you, Judge Davis. I know before we take the question in the back, Marcia, you wanted to comment?
The pregnant women. So if you don't know it, newborns, and I'm going to read this so I don't mess it up. Newborns exposed to opioids in utero have a 60 to 8% likelihood of suffering from NAS, neonatal abstinence syndrome, and it could impact the child's long-term growth, behaviors, language abilities, cognitive development, and academic achievement. And I guess we don't even know with some of these new drugs or what they're laced with, what that's going to do to these babies. Bowen Center gave us a report last week, I think. They're now running a program that if there is a mom that's addicted, they can enter into a program with Bowen Center. So the stats are they had 20 pregnant clients. Average length of service was 138 days. 4 of those were involved with DCS. The trimester when the client initiated, there were 4 in the first trimester, 13 in the second, 3 in the third. The pregnancy outcomes, there were 11 healthy births, 4 are waiting on due dates, and 6 have an unknown status, meaning they left the program, didn't come back. And so the good news is the total of NICU days reported was 0. There was an outlier set of twins with an extended issue, but that was not due to the opioid issue. So in 2015, the average Indiana NAS hospital bill was $86,399. And so the average Indiana non-neonatal abstinence stay was $3,500. So total hospital charges saved $912,000. So we need to get these moms that are addicted into a safe place so we can protect their children.
Thank you, Marcia. So as an employer, I'm sure those healthcare costs, dollar differences by just keeping one baby out of the NICU is a significant savings. But more importantly, from a developmental standpoint, that gives that child that infant a much stronger foundation to start out life with. And then especially with a mother that's no longer using. Sherry, question back.
A couple of things. First of all, for the employers, we added verbiage that allowed the employee to come forward to let us know that they were on something that would cause them not to operate a forklift safely, etc., so that we could work with them and that they didn't feel threatened. Their job was going to go away because of that. I have a couple of questions. One is the root cause. I have friends and family that have dealt with the pain management organizations in the community as well as outside of this area. When they go in and they're asked, what is your pain level? They know that if they give them a certain number, they get pain medicine. In a couple occasions, I went with them so that they had the strength to say, no, I don't want that, or I can't have that because I'm addicted. But the script pad was right there, ready to be signed. And these individuals, I would say, are respected individuals that have offered RFAs and epidurals and all of these different things to help with the pain. In one particular case, the individual had knots in the back of her back, and nobody was treating that. They were treating the pain. She ended up going to an acupuncturist, and within 6 sessions, they were gone, and no more pain. So she didn't have pain, but she thought she had pain. So she had to keep taking the pain medication. So I don't understand enough about how the insurances reward the medical profession in ordering all of these different tests. But if they keep ordering them and the patient thinks that this person knows what they're doing, and then they continue to then say, okay, now I need more, and I need more, and I need more, what as a community can we do to try to stop that? The second thing was I actively went to open NA meetings with a couple of individuals to better understand what goes on in those meetings. And in both cases, they said they didn't want to go back because they didn't find them helpful. That there were a lot of stories of people recovering and how well they did, but they sat there and talked about all of the things that they've done in their life. And it just kept reiterating that this is where I'm going. I'm not going to get better because it's just going to keep happening over and over again. So I would encourage someone to go to the NA open meetings and find out how they're actually trying to help, but I don't know that they really are.
Thank you. Maybe if we could start out, Dr. McMahon, would you want to talk about kind of root causes and kind of how did we get here to this opioid epidemic?
Kind of briefly in a nutshell, in the late 1990s, a report was published in the Journal of the American Medical Association that identified the fact that physicians were not doing a very good job of treating patients' pain. And that started a whole cascade of events that resulted in 2010, where we now have more people dying from accidental overdose deaths. Part of the questioning for the pain is the FDA got on board with trying to fast track, if you will, more pain medications. The pharmaceutical companies were very happy to produce more pain drugs and different versions of them. And I'm going to believe that everybody was well intended. They thought they were safe. They did not think they were as addictive as they were back then. And then actually the Centers for Medicare and Medicaid Services got involved. And what they started doing was reimbursing hospitals. Part of your reimbursement was based on how well patients' pain was controlled. And actually they instituted something called pain is the fifth vital sign. So no matter what you went in the hospital for, constantly you were being hammered about what is your pain level. Part of it, now this is my opinion, that's all fact, but my opinion is when you ask people about that constantly, what you're implying is at some point it should be zero. At some point I should be able to make your pain go away, which then really begins to set an expectation in the population that you're going to be able to make them pain-free, and preferably with a pill, not that dreaded physical therapy or losing weight or something like that. You're going to be able to do it with a prescription pad. Long story short, everybody owns part of this problem. You don't have a problem of this magnitude with just one profession or one set of doctors or anybody contributing to the problem. Everybody has to own part of this problem. But I will say, from my opinion, I think it was well intended. People have legitimate sources of pain. Now, part of the problem and one of the 21st century hurdles that we're hoping to work with our legislators and some other folks is that if you are in the medical profession now, it's very hard to get approval for some of these very simple. Some people are very easily treated with just some exercise, some acupuncture, over-the-counter NSAIDs, stuff like that. That's certainly a group of people. And some people have a higher pain threshold. They can have 2 hips replaced and a knee and they go home and just bite the bullet. But there are other people who don't have that same pain threshold that need their pain addressed. The insurance, we have a whole lot of new opportunities for pain management specialists to make interventions that can actually be non-opioid related. It may require a procedure, it may require a new appliance or a device or something like that. But if it returns and restores somebody to a quality of life and kind of selfishly, importantly, to be functional when they're working, so be it. But what's happening is now the insurance companies are putting barriers for those to be implemented, and they're making, we had one colleague who is a pain specialist who's in our opiate task force. He spends $120,000 a year on prior authorizations for some of these simple procedures. So again, we need everybody to come on board.
To comment on the Narcotics Anonymous, I work in the treatment field, and in the treatment field, I've been in almost 30 years now working in treatment, and part of that has been with addiction work. Back when I started, we clearly used what was called the abstinence model, and really you needed to stop all usage, whether it was alcohol or another drug. And Narcotics Anonymous and AA were self-help groups that were very impactful in helping change people's lives. And they continue to be today. However, I think, when we look at some of these substances and how highly addictive, we have to look at this as an illness, and as mentioned before, it's not a character flaw. And a lot of times it's not, it's not about, okay, I just can't do something anymore. It's really treating it like an illness. I mean, when you think about cancer, for example, it wasn't that many years ago that we had a lot of misinformation about cancer. And, oh gosh, if such and such has cancer, if I get too close to them, or if I, eat some of the food that they've eaten, will that have an impact on me? We had a lot of stigma, a lot of misunderstanding about cancer. And you think about how cancer is treated today as an illness and the different methods, whether radiation, chemotherapy, a variety of things, surgery and so on. There's many ways people are treated, and often this depends upon the type of cancer. Well, I think with addiction, what we understand today, and which is evidence-based practice, is that one size doesn't fit all. So for example, medication assistance treatment, which we would have never looked at 20 to 25 years ago, about no, if you're addicted to a substance, that we're going to go ahead and give you another substance so that it's more of a harm reduction. So there's a variety of ways to approach this, and there's no one single path that's the best, but what we do know about this illness is that if you can keep people in working some type of program for recovery, and that may be with medication assistance treatment, maybe with a variety of things, if you can keep them in for 5 years, that rate goes up over 80% of people recovering. And you think about a disease, and you think about, gosh, if you could stay cancer-free for 5 years, what that's going to mean. Well, with this whole illness of addiction, 5 years is a huge difference. It goes up. Actually, we know after 18 months, if you can keep people engaged, the success rate goes up significantly. So NA is a tool. It may not be the right tool for everybody, but it's a very good tool for a lot of people, and it's usually not used in isolation. So we have another question in the back.
Could you talk a little bit about around treatment that are happening in the city, or the research that's going on about innovation in treatment, expanding detox facilities or treatment for detox, because I know that's very important for them to be able to get off. And then the education in the medical community, you mentioned some of the drug treatment when they're coming off of heroin, what's happening in the city in those areas?
Would you like to respond?
In terms of education of professionals, we've really had to have a number of seminars to educate and engage the medical professionals to get them to begin to start offering treatment for substance use disorder, to engage them. We're also having some seminars for pharmacy folks and everyone. This is a big learning curve for healthcare too, because first of all, everybody's blaming them for the crisis, and then now we're looking at addiction as a medical problem now, rather than a mental health or social service problem. So really increasing our capacity really depends on engaging physicians and other practitioners. We have been very fortunate that we've had some practitioners come to town that are opening standalone treatment centers where people can have access to these, what we call medication-assisted treatments, Suboxone, Vivitrol, in some cases methadone, that actually will help people really markedly reduce the cravings that they have. Detox is extremely unpleasant, and every person who is going through withdrawal will tell you that it's the worst thing they've ever had. But fortunately, with opioids, it's not life-threatening like it is with alcohol. So those symptoms can be managed for people fairly simply by their doctors, but again, getting them on board to be willing to treat those people. And more importantly, the biggest thing is once they go through detox, we need to have some place for them to go to get treatment. So that's what we're really trying to do. And when I say developing this infrastructure, it's really increasing the capacity to provide those services. If you think that 40,000 people are struggling here, and that's not even including alcohol, if we're looking at that, we have a woefully short supply of people who are trained. but also people who are willing to provide those services. Because again, I think people have this image of who these people are and what they're going to look like and how demanding they're going to be. And that's why it's so important for us to have these opportunities to get out and spread the word that these are folks like you and me.
I want to digress for just a minute. I forgot to acknowledge Beth Locke. And Beth, if you hadn't been along with us for the Senate Bill 510, we would not be where we are today. So thank you so very much. We appreciate it.
I know we have another question, but before we get to that question, I'd like did not tell the panel this, but as this has evolved, I'd like you to think about maybe anywhere from 1 to 3 things that are potential solutions around this issue. We know that the opioid epidemic is not a sprint, it's a marathon. And we know it's going to take really a village and a lot of alignment to really make a change. But one of the things I want to make sure that we end in, before we end today, is that we're also talking kind of solution focused so that when you go back to your workplace, when you go back to your home, you have some things that you can think about that you might do that you could do that maybe makes a difference with this. Because again, this is a marathon. But just like nobody just gets up one day and says, I'm going to run a marathon tomorrow, and if they haven't been ever practicing and things like that, they have to start training. And so I would say for the panel, because we've got excellent experts up here, if they could just think about maybe 1 to 3 things that you would recommend. So, next question.
Yeah, I think that 40,000 was from 2015, right?
Well, that's true.
So if we look at the overdose numbers from 2016 to 2017, they've doubled, and maybe on rate to triple, so that's big too. One of the first things you guys brought up was what does an addict look like? And I'm a recovering addict. In a couple months, I'll have 3 years clean. I'm the only... And I'm the only person in my family who does not have a college degree. Basically, I think most of my mom and dad both have their masters, and so like it's already said, there's no socioeconomic boundaries to it. And I'll get to my question. I was just going to touch on a couple things real quick. One of them was what the lady said over here about the Narcotics Anonymous meetings. Just because you go to one meeting and you don't get, what you wanted out of it, me thinking from an addict's point of view, if I went to one drug dealer and I didn't get the drugs that I wanted, I wouldn't just call it quits and stop. I would try something else. So I encourage people to, go to, there's Cocaine Anonymous, Alcoholics Anonymous, Narcotics Anonymous, there's Smart Recovery, there's a lot of different resources out there for people in there. And if there's employers, I don't even know who's here, but there's employers out there talking about getting to treatment. Get with me after this, and I'll talk to you about that as well. Also talk to you, Wendy. So getting to my question was, we're talking about solutions. That's something I always like to talk about whenever I do any speaking. And something that I think is crucial is the pharmacies. You mentioned something about the pharmacists. So, I take blood pressure medicine, other types of medicine, and when I go to the pharmacy to get it filled, it's usually, have you taken this before? Do you understand the instructions? I say yes. I think when I sign that box, correct me if I'm wrong, Dr. McMahon, but that means that I basically just signed away I signed liability off of the pharmacist. So, if we could get do you think there's a way that we could get the pharmacist to kind of ask you, talk about those questions when you go to your family doctor? I think they do it annually once a year, but they ask you, have you been suicidal? Have you had any thoughts of that? Is there any of those pre-screening questions that we could get the pharmacists and pharmacy technicians to say, hey, do you understand that this medicine could possibly be addictive? And there is a clear difference between being physically dependent and being an addict too. So that was my question.
Thank you, Mickey.
Yes.
Who would like to respond?
Yes.
I think that's a great idea. We're actually having a meeting with the pharmacists on October 9th, a pharmacy seminar. That may be something that we can bring up. It's a good idea.
Thank you. Well, kind of, whoops, looks like another question. Go ahead.
Just wanted to ask, just to follow up on, mention, I think it was Marcia said something about data. And we need more data to get better funding so that we can have resources for whatever needs to be developed. So can you just speak to what's needed? What is it from healthcare providers, from law enforcement, from the judicial system? I'm just trying to figure out what is needing to be collected that other states have been more successful with that we haven't captured.
So this is one example. There was some bill, Beth, I don't even remember which one, but it didn't pass, and what it was supposed to do was to get all of our coroners to agree on how they were going to report. So coroners are elected, every county has their own coroner, and their coroner does it however they do. Some coroners, ours are really great. So if we don't have a systematic approach to collecting that kind of data to show here are the overdoses, here are the overdose deaths, here's blah, 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 that's what we don't have. So somehow we've got to rally and talk to our legislators and tell them how important it is that we do that so we can begin to collect data. I was at some place and I reported some data that I had from the Indiana Department of Health, and somebody goes, Marcia, those numbers are way off. And I said, what do you mean? That's what was reported. That's the problem. It's what was reported and it's what's not reported.
Thank you. I had one more question about detention. So I know it's not a law problem, right? Because it's a medical issue, addiction, drug overdoses and such. Once the person's stabilized, they need help. They really are in imminent harm seems obvious to family and loved ones. Maybe even the patient is saying, if I leave here, I'm going back to get it. They wake up after having Narcan and that sort of thing. So the emergency department is inundated. 72-hour detention has a place. It's not always right for the use of this, but the patient's in imminent harm. So I feel like all the people involved in detention need to get on the same page in some way so that we're not junking up the system and only having them go to that 72-hour detention for their safety when there are resources that can actually help reduce the patient harm potential. But I feel like that's blurry. If this is a medical addiction problem, what do our ED providers? We can't leave them go on the street. We need a safe discharge plan. It's not your inpatient psych. This is a medical issue. Maybe they don't have a secondary psych. So just some thoughts about how we might think about the future there.
So to answer that, one of the things that Indiana is doing is a peer support program. Especially a lot of emergency departments do not have mental health therapists that come into the ED. And so they're really, actually I think there's an RFP out there, request for proposal in Indiana in EDs throughout Indiana to have peer support. So as Mickey talked, and again, Mickey, thank you for sharing your personal situation, and sometimes having somebody who's been through it and is working a program of recovery that you talk to, because a lot of times, my experience with this is you've got to strike when the iron is hot, and one of the best times is when they've just overdosed and they're in the ER. But you do need to have somebody who understands motivational interviewing and really then a path of where to get help. And I would agree, Christina, that it's not always that 72-hour detention. Sometimes can be way overutilized. But there are other intervention strategies that are being used and some evidence-based practices out there. Before I ask the panel, I know there was one more question in the middle table. Oh, two more. Okay. And then we'll cut it off after two and get the panel's ideas on solutions.
I work for Innovative Professional Services, which is a private detox and rehab facility run by a physician and an addiction specialist, both who have been clean and sober for over 25 years. We do medical detox, but we also use Vivitrol. And I heard you mention Suboxone and methadone. And I'm wondering where we are with the difference between Suboxone and methadone and Vivitrol, in that we see people coming in addicted to methadone and Suboxone in particular seems to be even worse to get off of than heroin, which is not the case with Vivitrol. So it's always concerning to me when I hear that Suboxone and methadone are considered being used in treatment. So I'd like for you to address that if you could.
Good point. Vivitrol is actually the drug of choice because it has no street value. And it's something, the thing that I really like about Vivitrol, it has an injection advantage where you give one shot and it lasts for 30 days. What these drugs do is help with the cravings. You also don't get any high. You get a little mild high with Suboxone. Methadone is more intense. Most people who provide MAT are in favor of either Suboxone or Vivitrol, and methadone, because it has a high risk ratio, is not really much in favor except for people that have been addicted for a long time. My opinion is both of those are considered to be valid choices, and I understand your concerns about that. And we're seeing that the Suboxone is causing a problem. What I wonder if that really reflects, and this is my personal opinion as a physician, is that the drugs that we're talking about now, the opioids we're talking about now, I think we have to consider the fact that there may be people who have been on them for so long that they may never get off Suboxone. They may, just like some people never get off insulin. You don't put people on insulin for a while and then hope, yes, there's some people that then will diet and exercise and their bodies will accommodate and they can eventually go back to oral medications for their diabetes. But some people are just on insulin. There may be a fraction of people, and that's, again, I think the science is evolving here. We have very little experience with the drugs that we're talking about now that are on the street. That Captain Hunter is describing, the impact that is having on the brain is absolutely frightening to me as a scientist, as a physician. We don't have the knowledge of what that's going to look like in terms of ability to function later for restoration of the prefrontal cortex. We don't know what that looks like. I think we have to be honest about that. I think we need, as times change, we need to be flexible and let the science evolve and dictate to us. I'm sadly thinking we're going to have to accept the fact that there may be people, especially if they started very young in life, especially if they started using drugs that were hardcore, those people may need a Suboxone for the rest of their life. But there's no question that I think most people would like to be able to use the Vivitrol because of the simplicity of it. And to me, it takes the choice out. You don't have to make the choice every day. Do I eat the donut? For me, do you? For that person, do I take the drugs? That kind of, they have a little break in having to fit, because I don't think you understand their craving. Drugs impact your reward system 10 to 20 times more than a really good meal. Really good show or vacation. That good feeling you get after you do something like that and you feel good, everything. Drugs pound that. You are always chasing the dragon. You are always chasing that high. That's what these drugs, the Vivitrol, the MAT, help restore over a period of months, restore that reward system so you can actually get pleasure again from playing with your kids or having a good meal. Because that's gone. When you're on those drugs, nothing you do other than the drug will ever make you feel good.
Thank you, Dr. McMahon. One last question, I think, back in the room.
Do you have any advice for companies that are considering stocking Narcan or AEDs or something like that, just on the chance that somebody's going to OD on their property? And what are the training and liability issues associated with that?
Well, the training is pretty simple, and if any... Okay. The training is actually pretty simple, and if you call the Department of Health, we're happy to come out and show you how to administer it for your staff to administer it. So the training is pretty simple. The liability, Good Samaritan, if you resuscitate somebody, you have no liability. It's a Good Samaritan law. I think that was passed in the last year or so. But what I want to highlight, and it was something that we were talking about earlier, is that Narcan is the beginning. Without increasing our capacity to provide medication-assisted treatment, administering Narcan, even a 72-hour detention, administering Narcan is like doing an AED or CPR, but the cath lab is closed. You are resuscitating somebody, but if we don't have the capacity to provide the treatment for the root cause of that, we are sadly, sadly never going to get a handle on this.
Does anybody else want to respond to that? Okay. Well, thank you. So now, opportunity for each panelist to really kind of talk about maybe 1 to 3 solutions or things that could be implemented.
Of course, I'm very long-winded, but I'll try and be short. I think the first thing is we really need to develop a really functional collaboration between medicine, mental health, employers, pharmacists, and law enforcement to develop workplace policies and then EAP programs that are really 2.0. They really address this issue. And you've got to have those policies in place. And I don't know why each agency or business should do it on their own. Why not work together to develop some models that then can be tweaked for each business to use? But you need that collaboration. HR is not going to be able to do this on its own. It's a very complex issue, and you want the input to get a functional program. You want the input from all of those disciplines to create a program that's really going to last. The other thing, and Mary Hessel, my board member, will shoot me, but we need mandatory required school education about drugs so kids understand the science behind it, not just all the sad stories about little Johnny who didn't make it and didn't get to be the pharmacist he always wanted to be. But I mean, this is what it's doing to your brain. Most people do not know it is putting holes, physical holes in your brain. And for most of us, unlike Marcia, where this is the moneymaker, this is the moneymaker for most of us, okay? This is what keeps you afloat. And people are damaging that. Kids need to understand factually what is happening to them, and they need to understand what mental illness is. They need to understand and be able to put a diagnosis to the feelings they're feeling and be able to talk to somebody. So we need education to talk about drugs and mental illness. And the last thing we need to do is we need to normalize mental illness. Depression is just a medical problem above the neck. Anxiety is just a medical problem between the ears. That's all it is. We treat them in very same ways. It's never just drugs. It's always a combination. Just like when you have diabetes, it's diet and exercise and medication. This is cognitive behavioral therapy and medication and counseling. But we have treatment for that. We need to normalize that and get people diagnosed and into care.
Okay. Everything that we've talked about is not sexy, right? So if I come knocking on your door because we're trying to raise money for sober living facilities, I want you to open up your mind. And I want you to tell me who else I should talk to. Because we as a community have got to be able to raise funds in addition to Senate Bill 510. And we are applying for CURES dollars as well. But sober living is one of my #1 things that we as a community have to work on. So money, sober living, we the Lutheran Foundation developed a resource called lookupindiana.org. It really started when Dr. McMahon said, let's get this task force together and let's map out where you go for treatment. And so along with the study that Chuck referenced earlier, people didn't know where to go, they didn't know who to see, they didn't know what questions to ask, and then add stigma on top of that. So this is a resource that we continue to build. We hear from people about, oh, now we want this, we want this, we want this, so we're doing that. We have a 24/7 text to chat or web to chat. We partner with Remedy Live, and the hits they're getting, it's amazing. And then we also partner with Parkview Behavioral Health. There's a 1-800 number, and it's a crisis call 24/7. So we have all kinds of information. I think you can go see Chasing the Dragon there. There is a student page, and we have all kinds of find your provider, find out more information, that kind of thing. So I have some of these cards with me. I think we have distributed, we serve 10 counties, I think 60,000 cards since last June. We print them by the thousand, so take handfuls back, lay them out, give them to people, do whatever you want. If you need more, let me know. 2 more things. The Lutheran Foundation also initiated a regional mental health coalition for the reasons that Dr. McMahon said. And we have each area represented. So we have business, we have law enforcement, we have education, we have health, we have faith-based, all of that. So then we have a leadership coalition, and there are subgroups that are working on different matters within those. So know that that's there. If you want to be a part of it, let me know. The last thing is, I'm going to speak for all 3 of us, and I'll speak for Andrea, the mom whose daughter overdosed. we are willing to talk to anybody and everybody that will listen to us. And so we're trying to figure out what's the right way to do that. So if you have a group that you're a part of, or your church, or something else like that, let one of us know. We can slim it down. I mean, we can do a TED Talk, we can do whatever you want. But we believe that people on the street, real people like you and us, you and me, you and us, need to know about all of the stuff that's going on, so that they don't think that it's somebody else, but it's us.
Into a facility right then and there. So that's another huge thing. And then just keeping addicts alive. People who are suffering from substance use disorder, if they're dead, we can't get them into treatment. And that's one of my goals, is to try to keep these people who are suffering alive so we can get them healthy again and being productive members of society.
I want to thank the panel. I mean, I think that the expertise that's sitting up here, and then also just hearing of the resources and things that are going on in this area. But I appreciate, because like I say, I didn't really mention anything about kind of give me some top 3 solutions. But you do have something that you can kind of take back, because this epidemic really is going to take a village. It really is a marathon. It's really going to take a lot of work to make a difference. And I appreciate the audience's participation today. We could all give a round of applause for the panelists.